Really great to see some familiar names and faces. Just wanted to have everyone, whenever you're ready, we're just gonna make a start. Just a reminder to click on your interpretation button and choose your language of choice, English, French, or Portuguese. And we're hoping to we're testing to see if we can actually record the French and Portuguese versions so we can put that online. I think, and we're just gonna, let's just get started. So I'm going to share my screen, I think, oh, okay, I'm gonna share my screen. I'll just do hi everyone, my name is Felicia Wong. I'm the head of innovation at Frontline AIDS, and welcome to the Frontline AIDS and LVCT Health session on female genital schistosomiasis, and I'm going to end HIV integration. And I, of course, will need to try and figure out how to share my screen as usual. And we were just going to make a start. Okay, let's see. That is going to work. Is everyone seeing the title slide? Is that what we're, great, thank you.
Yes.
I'm going to see if I can figure out how to. All right, so welcome. So this is just I guess this is I've been working on heading up the innovation team. We've been looking at different opportunities around working differently around HIV prevention, women and girls health, and LVCT Health and ourselves have been working on linking and actually integrating female genital schistosomiasis and HIV. And FGS, I would say FGS in the meantime. It's much easier to say, much shorter. And I guess this session is to just share really more broadly around the connections between schistosomiasis or Bilharzia, as many of you may know it, as with HIV. And so, the exciting thing is that we actually, LVCT has a operational research project, which Robinson's here to share with us about. And also my colleague Isis will be speaking, and she and I are working very closely with Robinson as well around establishing an FGS integration group or a coalition looking at integration for FGS. So really this session is introduction to FGS. What is the relationship between Bilharzia or schistosomiasis and HIV and sexual and reproductive health? Sharing a bit of the practical on-the-ground experience that LVCT Health have had in Kenya. And then really it's just a discussion or kind of a conversation about what this might mean and reactions from people, because we've had a lot of little kind of conversations around FGS and HIV, but kind of across the partnership, we haven't had a space to discuss it, and we're really hoping that this is actually one of many conversations. And this is very much, I'm not sure how familiar everyone is with the Frontline AIDS strategy, but this very much sits in what we consider Action 6, or investing in solutions around innovation. And we very much, I think all of us who are working on this FGS HIV integration is very much seeing this as not just an innovation for HIV prevention, but innovative health partnership across sectors that we would have never typically thought about partnering. So, I'm trying to figure out how to, I'm going to hand over to my colleague, Isis, and she works both for Bridges to Development as well as does work for us at Frontline AIDS around FGS integration. And I think Isis and Robinson, just let me know. I'm having trouble figuring out which bits to look at on my screen because of the screen sharing, but I'll just continue the screen sharing, and I'll just hand it over to Isis.
Thanks,
my camera off.
So let's start our session before explaining what are neglected tropical diseases. Neglected tropical diseases, or NTDs, afflicts 1 billion people in 149 countries, and schistosomiasis is one of those entities and will be the focus of this presentation today. Schistosomiasis is prevalent in tropical and subtropical areas in communities of poor people without access to potable water or adequate sanitation. It is common in rural areas and in undeveloped urban areas where communities rely on open surface water sources, such as rivers, streams, and lakes for work or daily chores. It is estimated that more than 200 million people require preventive treatment for schistosomiasis worldwide. About 90% of these live in sub-Saharan Africa, of whom an estimated of 20 million are adolescent girls aged 12 to 19 years old. There are two major forms of schistosomiasis, intestinal and urogenital. And on today's presentation, we will focus our attention on the urogenital presentation of the disease. Next slide, please. But why FGS, or female genital schistosomiasis? FGS is a condition related to infection with a waterborne parasitic disease, and it is caused by infection with the parasite S. hematobium. FGS results from the setup of schistosomal eggs in the vagina, cervix, uterus, fallopian tubes, or vulva. When FGS is untreated, it frequently damages the reproductive organs irreversibly. Up to 60 million women in sub-Saharan Africa have FGS, and the mean prevalence for S. hematobium, the parasite that results in FGS, is 24.7% in sub-Saharan Africa. 2 in Mozambique, and 2 in Mozambique is the highest prevalent country, with 47.1% of school-age children infected, as you can see on the map on your right. Next slide, please. How does the transmission cycle works? Transmission occurs through skin contact with warm and contaminated fresh water in more than 44 countries in sub-Saharan Africa. Transmission occurs when people suffering from schistosomiasis contaminates freshwater sources with their excreta containing parasite eggs, which hatch in the water. Schistosomiasis mostly affects poor and rural communities, particularly agricultural and fishing population. However, women doing domestic chores in infested water, such as washing clothes, are also at a greater risk and can develop female genital schistosomiasis. The symptoms of schistosomiasis are caused by the body's reactions to the worm's eggs. Let's take a look then on how is the disease presentation. So next slide, please. How to diagnose FGS. Women and girls with urogenital symptoms and who have had contact with fresh water. They will present vaginal discharge, bloody discharge and bloody urine, bleeding after intercourse or spotting, genital itching or burning sensation, pelvic pain or pain during or after intercourse, and girls may present with some of the above symptoms or some of them. So FGS then is characterized by weakness of the vaginal mucosa and ulcers in the cervix, leading to all these symptoms that I just said before. But especially because of this weakness of the vaginal mucosa, it's thought that this increases women's risks for HIV acquisition in the same way that, for instance, ulcerative sexually transmitted infections increase susceptibility to HIV infection, HPV, and STIs. All of women and girls infected with S. hematobium the majority of them will have these lesions. Many have genital schistosomiasis without urinary excretion of S. hematobium eggs. Next slide, please. And what are the complications? There is bleeding during examination, infertility or secondary infertility, miscarriage or ectopic pregnancy, involuntary urination when coughing, laughing, or jumping, genital ulcers and open wounds, tumors or swelling in vulva, vagina, or cervix, and other complications of schistosomiasis itself that include anemia, malnutrition, stunted growth, abdominal cramps, learning difficulties, and school absenteeism. Moreover, complications of schistosomiasis impact people with HIV and their ability to take ART. Next slide, please. And how to prevent all of these? If one FGS case is seen, there are probably many others in the same area. All who have used the same source of water are at risk. Second, we need to identify persons who may have early schistosomiasis, but especially in endemic areas, the regular treatment of young girls during mass drug administration to communities and schools is important in order to prevent FGS. And what is mass drug administration, or MDA? MDA involves giving treatment to every member of a population or every person live in a defined geographical area. Praziquantel is one of the only medicines that can treat schistosomiasis, and it is included in a WHO list of essential medicines. Praziquantel is the recommended treatment against all forms of schistosomiasis. It is effective, safe, and low cost. Even though a infection may occur after treatment, the risk of developing severe disease is diminished and even reversed when treatment is initiated and repeated in childhood. Another thing that we are strongly advocates for is integrating schisto prevention into HIV programming. And that's why the rationale behind this is leveraging the HIV experience on doing integration. So the question for our group today is, what are the opportunities to integrate FGS and schistosomiasis awareness in our HIV programming? Next slide, please. Okay, and what are the public health implications of all this? First of all, FGS may be the most common gynecological condition in schistosomiasis endemic areas. And FGS usually falls between the cracks of neglected tropical disease and sexual and reproductive health programs. FGS, and the problem of this is that the signs and symptoms of FGS are often mistaken for those of cervical cancer or sexually transmitted infections, and misdiagnosis can lead to multiple visits to healthcare providers, as illustrated in the figure in your left. And this increases the burden of the patient and the healthcare system. And this is potentialized as healthcare workers are usually unaware about FGS. Moreover, stigma experienced by women and vulnerable women because FGS presents with STI-like symptoms. Women living with female genital schistosomiasis are at greater risk for HIV infection and poor sexual and reproductive health outcomes. Women live with HIV who also have FGS and schistosomiasis experience, they experience faster disease progressions to death. So let's go dive in a bit on the evidence around these statements. So on figure A, B, C, and D illustrates the overlapping geographical distributions of schistosomiasis infection, HIV prevalence, reported case of FGS, and infertility. Though the risk factors for HIV and schistosoma hematoma are different, these two conditions share substantial geographical overlap, as you can see in figure A and B. In addition, schistosoma infection in women, and more specifically FGS, has been associated with prevalent HIV infection. Moreover, the distribution of secondary infertility, therefore infertility after giving birth to a child, overlaps also substantially with the distribution of FGS in sub-Saharan Africa, indicating possibly an association with this reproductive issue and this parasitic disease. Next slide, please. So the facts are, one, that it seems that S. hematobial and HIV epidemiology may present an ecological association. Two, FGS seems to work as a risk factor for heterosexual acquisition of HIV. Three, schistosomiasis seems to work as a risk factor for HIV incidence and transmission. And four, FGS may enhance HIV susceptibility. Next slide, please. But how this association is described? So this image illustrates the conceptual pathway and reveals several hypotheses for how FGS may influence mechanisms associated with HIV-1 acquisition. In other words, this image tries to answer the question, does FGS behave like an STI or bacterial vaginosis in heterosexual HIV acquisition? So the red arrows illustrate well-described relationships between mechanisms associated with HIV. We have STIs, vaginal inflammation, and no optimum factors, and therefore they may enhance HIV susceptibility. Moreover, more research is needed, but all indications point to this direction, that FGS increases the chances of HIV susceptibility. Very briefly, on the next slide, you see the same, those same conceptual pathways are found on FGS association with cervical cancer. But now I will give the floor to my colleague Fee to talk a little bit more about stigma and violence. Thanks.
Thesis. I think also, in addition to the physical kind of biological aspects, FGS integration with HIV and cervical cancer and sexual and reproductive health, really, I think it's another entry point around addressing stigma and violence. So in addition to the physical symptoms and complications of FGS, it also contributes to stigma and violence experienced by women and girls. And I think, from the kind of the start, we think, gosh, women and girls regularly are experiencing unfair, unequal treatment, faced in discrimination, and experience violence by the mere fact that they're female, or women and girls. And then, you take it another kind of step, and women and girls who experience sexual and reproductive health issues, such as difficulty becoming pregnant, experiencing vaginal discharge or vaginal odors, they face further stigma and violence from healthcare providers, families, spouses, sexual partners, and often communities. Because FGS is often misdiagnosed as a sexually transmitted infection, that means that girls and women who present with STI-like symptoms may be accused that they are either, having had sex or being, having affairs or having sex with other people, just like that whole, I think that range of kind of discrimination and stigma and taboo related to sex and women and girls. And may also just, I think lead to violence and other types of social exclusion. And so if we make that connection around that biological connection that Isis was talking about, that, that the scientific biological, and we're now also saying, actually, there is this wider social, economic connection as well, which we are well placed from working in the HIV community around stigma, discrimination, inclusion. And we know that it's widely documented that women and girls who experience violence and sexual and gender-based violence also have an increased risk for HIV and other unintended pregnancy, as well as sexually transmitted infections. So FGS integration really provides an additional entry point to address harmful social norms and practices, address gender inequality, and prevent gender-based violence, and supporting women and girls who have experienced sexual and gender-based violence. So in a way, it's bringing together, again, that community and health systems response for women's health in a more holistic way. So now we're going to move on and talk a little bit, and I'm going to be very just around FGS integration, or FGS itself, has gained this momentum over the last few years. And I'm not sure if people will remember, but in 2019 at ICASA, you'll see that this first policy reference or policy guide by WHO and UNAIDS, No More Neglect, was talking about FGS and where it sits in women's health services. This year, when UNAIDS launched their new strategy, addressing schistosomiasis and FGS were considered key interventions around creating impact for HIV prevention and just progress on the indicators for HIV. And then finally, it's also been included in some of the most current WHO NTD strategies going forward. So it's out there. It's getting out there. There is this building momentum and awareness of FGS, and in particular in its relationship to HIV and cervical cancer and that broader sexual reproductive health. This was early last year in 2020, where this framework for FGS, HIV, and HPV cervical cancer programs was released by WHO. If you're to look up WHO bulletin and just put in FGS, you'll find the bulletin that is specific to this, and you'll see there's real areas for integration around FGS, HPV, cervical cancer work, and HIV work. One of the things that this diagram doesn't explicitly show is really that those intersections with broader women's health and the opportunity that looking from the FGS lens brings, including antenatal care and perinatal care. So again, this is looking at FGS as an entry point for broader women's health, connecting, I think, a lot of women and girls who may be left out of the public health services, and also a lot of the women and girls and people that we work with in the HIV community, their key populations. So really this is has such a wide benefit, and it gives us, I think we've worked a lot on really broad SRHR, sexual and reproductive health and HIV integration. And in a way, this is honing it down, but then also leveraging the experience we've had for women's health as well. So now, I'm going to hand over to my colleague Robinson at LVCT Health, based in Kenya, to speak a little bit, actually, just to tell us about their project, which is leveraging the community-based health experience for FGS and how they're doing it in Kenya on the ground. So I'll hand over to Robinson and for you to take the floor.
Okay. Thank you very much, Felicia, and thank you very much, Isis, for really setting the stage for for me to share the experiences that we've had with Frontline AIDS and other partners around integrating health education around FGS in HIV prevention settings. So we piloted this integration through an implementation science project in partnership with Frontline AIDS, SCI Foundation, and even government institutions such as the Ministry of Health, then the Homa Bay County, which is a sub-national level of government, and the Kenya Medical Research Institute, based in the western part of Kenya. And we were able to do this work with funding from Core NTD, which is also funded by UK AIDS. So next slide. Yeah, so we set out this this project to build on the calls for integration, or calls for integrating FGS or schistosomiasis into primary healthcare and even HIV, community-based HIV prevention settings. And building on what Felicia has presented about the UNAIDS strategy, the Global AIDS strategy, and the roadmap for NTDs, the Ministry of Health also developed what we call the breaking transmission strategy, which has 6 pillars for breaking transmission of entities, including schistosomiasis. And one of the key pillars was integration of this intervention. So that was our, that's what we were leveraging on. And the place where we worked, which is Homa Bay County, is in the western part of Kenya. In this part of Kenya, we have high prevalence of HIV, which is at about 18.5% in the population. And recent, well, not so recent prevalence data showed that schistosomiasis prevalence, especially hematobium, ranges anywhere between about 10% to 25%. And there are so many interventions that operate in silo. So we're trying to see how leveraging all this is going to help in increasing awareness about schistosomiasis. So it's a study that we started late last year, and we'll go up till November, end of November. So we implemented the project until September, and our population was mainly adolescent girls, the community, and the health workers. Next. Yeah, so the idea around our pilot project was to integrate FGS information onto an already existing peer-led community HIV prevention program, which is referred to as DREAMS. And it's a 5-year project that's funded by CDC PEPFAR. And now the DREAMS project really aims to at preventing new HIV infections and unintended pregnancies, targeting adolescent girls and young women aged between 10 and 24. And this program also targets school-going children. So out of the several interventions within the DREAMS program, the safe spaces, which is a safe area where adolescent girls and young women go to seek HIV testing services, and other SRH interventions. And we thought, why don't we layer in health education about schistosomiasis, referral, for girls who present with symptoms that, are highly suspicious of either urogenital schistosomiasis or female genital schistosomiasis. So that was one component where we leveraged our integration. The other place where we leveraged is around the community health interventions, where as community health volunteers seek service or deliver services at household level, they also ask the household members if there is a household member that has shown signs of blood in urine as a proxy indicator, and they help in the referral and backward referral, and also providing health education. Community outreaches was one other area we wanted to leverage on, but we didn't dwell on this one so much because of the COVID-19 pandemic that hit the western region of Kenya. So our primary focus was around safe spaces, community health services, and one more area that we added was in the primary facilities, we sensitized health workers about FGS because, and you'll hear that later on in my presentation, a lot of health workers were treating people who had symptoms of FGS or suspected symptoms of FGS, as we came to find out, for STIs. So there was a lot of use of antibiotics for treating conditions that looked like STIs, but we'll talk about that later. Next slide. Yeah, so the 3 key objectives for us was, first of all, was to assess what do the community and the health workers know about FGS. Then after establishing that, would design our intervention based on the evidence we collected, then implement an integration strategy within the community, then now assess the effects of some of these, some of the outcomes, or the short-term outcomes of this integration. Next. So the next is just a schematic that shows at the very beginning, during our formative research stage, we really learned, what are the terms that people use for FGS like symptoms, for schistosomiasis, and also worked with the community members using very participatory approaches to tell us where the hotspots are, what they believed about schistosomiasis, and just using the local wisdom, knowing what community members, or rather getting information about how they would want us to address some of these challenges around FGS, and how we can link that to HIV to make to make our interventions more acceptable in the community. So we just completed the implementation phase, and we are currently finalizing on our assessment. Next slide. So the next slide basically just shows what data we collected at the formative stage at the beginning of last year, through qualitative methods and a quantitative survey. Then we implemented our interventions between March of this year up to September. So we had a good 6 months of implementation. Then went back, did a qualitative assessment, and now we are finalizing on the final report based on the assessment that, the findings that we got in August. Next. All right, so I'll dwell a little bit more on this slide. So I'll start with the top right, where we integrated FGS and schistosomiasis education in the safe spaces, where we reached a total of 25 safe spaces, which were either schools, or they would be in church compounds, or some of them would be in the girls' homes. So where we would teach them about FGS and schistosomiasis as we delivered HIV-related services. So we're able to reach at least 1,700 girls through this intervention, and delivered that the health education, and even using materials that we tested together. But we'll talk about that a bit more in the next slide. Then we also sensitized community health volunteers in the region, where we reached about 61 of them, and they used handbooks that we co-developed as they did their door-to-door delivery of health services. So we trained 61 CHVs, and even some of the DREAMS mentors. I think they should have been about, I can't remember the exact number. We reached quite a big number of we sensitized quite a big number of community health resource people with education about FGS. So in our formative stage, we realized that many of the health workers did not know what FGS was all about. And in that area, there were government-led interventions for detecting or for screening cervical cancer. And there are also some NGOs that were running cervical cancer screening programs. So when we looked at the content, we realized a lot of FGS was not mentioned in the curriculum. So we jointly developed content on FGS, targeting providers who do pelvic exams, and integrated that into cervical cancer screening programs. So we screened, we trained some of these health workers, and the health workers were really excited because during the training they were able to pick up cases of FGS, which would have otherwise been misdiagnosed as either STIs or early stages of cervical cancer. So that was a really helpful addition that we made to the program. And then we also used radio programming. We used vernacular radio. Initially, we thought we'd only reach the small geographical area where we were working, but then people were calling us from far-flung counties, and there were, the audience was very engaged. So you can tell there's a huge demand to address some of the myths and misconceptions around FGS, not just in our local area, but people from various, vast geographical reach. So those are the interventions. Next slide. All right, so these are some of the materials that we shared. Some of them we developed, we co-developed with the health managers and the community stakeholders. So we co-developed the CHV training manual on FGS and schistosomiasis with the community. The FGS, that should be FGS Health Education Toolkit, which we also piloted and rolled out. And then the training slides on FGS for integration into CA cervix screening. And then now We also co-developed community posters using the local language and where we picked the terms that the community use and are comfortable with. So we also shared the World Health Organization FGS Atlas, either in pocket books, so that health providers would refer to as they were providing education. And we also supported with the posters, for the FGS Atlas. Next slide. Yeah, and just to mention that we'll be happy to share these materials that we co-developed for use in other settings. So this slide has some transitions, so feel free, Felicia, to click on all of them. So at the very beginning, we found high levels of stigma in the community because a lot of this stigma was associated with, they would say people who display the symptoms of schistosomiasis or FGS were either promiscuous, or being judged as that, or it was deemed as a curse. So that's one thing that we picked up from our community. Health workers also were not aware about FGS. There was also quite a lot of misdiagnosis of FGS and schistosomiasis. I touched on that earlier. And there was also a lot of self-medication. Self-medication because when people found themselves to have symptoms of FGS or schisto, they would go to a local pharmacy, buy drugs, or sometimes they'll go out seek herbal treatments, which more often than not would not work, and they would keep displaying these symptoms. Next. So we decided to keep our research findings pretty high level so that we can have more time to discuss the integration and the advocacy efforts. So we'll really just present very high level findings. And so when we went back and did the qualitative assessment after 6 months of implementation, when we asked the question about the feasibility of integrating FGS into HIV and SRH settings, yes, it was perceived to be quite feasible because, one, they did not have to employ different people and create silos for the different interventions. So it was possible to deliver these services in one go. There was, from our FGDs and from our interviews, yes, we found that integrating this information about FGS and schistosomiasis heightened awareness about FGS in the community. And there was quite a bit of precaution about how much time to spend in the water, because about 40% of the residents in our study area use the lake. 40% use the lake where they get infection. And also about 25% use inland water sources like rivers and ponds. So awareness was heightened in that community. Of course, there was feedback that we shouldn't be very ambitious about having integration happening immediately. So there was feedback that it's taking time, and of course that is true. We may need more time to see good outcomes because we had only implemented this intervention in about 6 months. So our advocacy efforts are targeted at creating sustainability for these interventions. And of course, there were some small gains because health workers were beginning to sensitize women who are coming for antenatal clinics during what they call micro teachings. They would gather the women outside the health facility and give education about ANC, about HIV, and also throw in content about FGS and schisto. So we are witnessing baby steps, but then this will take time. Next slide, Felicia. So we reflected on what worked and what contributed to us seeing some of these positive findings or outcomes in the short run was the coordination. We really coordinated a lot with the National Ministry of Health level and the sub-national health services departments, which are the county government. So we worked very closely together, and that was very useful. Leveraging on experience that already exists, worked with the community health volunteers, using whatever platform they are working on, such as Dreams, and just adding on small content on FGS, and it doesn't feel like extra workload for our stakeholders that we're working with. Co-production was very useful for us. You'd find the photo, the gentleman on the right was one of the community leaders. They'll draw the community maps and show us where the hotspots for hematobium, or rather for urogenital schisto are, where the people fetch water and where they see a lot of people exhibiting blood in urine symptoms. So it helped us with the targeting and also ownership of these interventions. I'd mentioned about community level structures such as the leaders and the health workers themselves were very useful for us to propagate or to spread the messages around FGS. Finding opportunities such as Dreams was very helpful, and capacity development is very crucial. Building the capacity on how to identify FGS as they do pelvic exams, as health workers do pelvic exams, and even proxy symptoms like blood in urine. Just creating awareness on identifying some of these symptoms was very helpful for us to increase referral and also management. Next slide, of FGS. So these are some of the recommendations we also shared with the county government sometime 2 weeks ago. And financing of schistosomiasis control came up, and they agreed that indeed it is a problem because at the moment we have zero budget for addressing schistosomiasis and FGS. So there is acknowledgement of a problem. So those are the baby steps of advocacy, and we are focusing the next 2 months, that's October and November, to really focus on encouraging or advocating for the budgeting of schistosomiasis, budgeting of care and treatment, and also prevention in the program-based budgeting. So we are at that stage, and want to make sure that this at least gets into the county health financing agenda. The next area is building up on capacity building, incorporate relevant schistosomiasis training, targeting health workers and community health volunteers, and even integrating schistosomiasis control in different other budgets, such as environmental budgets, public health budgets, because they're currently in silos. So as environmental specialists fix or address environmental challenges, why don't they build in vector control mechanisms or interventions into their budgets? And also, I think I mentioned number 4 earlier as part of health financing, integrating FGS prevention and control or care and treatment budgets into other budgets such as reproductive health and HIV. Next. So I guess that's all for me, and I'll hand over to Felicia. Thanks, Felicia.
Thanks so much, Robinson, giving us that really on the ground view of what integration can look like and really the possibilities of it. And I really like what you're saying around how it's building on what exists instead of building something new, because I think we often fall into that trap around it's a new idea. Do we actually have to build something new? And so I think it's a great example of how it's integration on all levels, all the way to the budgeting at local level. Thanks so much. I do have some questions for you, but I'll wait till the Q&A. So I just want to take a couple minutes actually to share a little bit more around FIG, or the FGS Integration Group. So now I'm going to be one of the people who have to run a slide set and do notes. Let's see, that's not, there you go. You can see the slide sets, I believe. As you've been hearing about FGS and kind of where it sits and where it doesn't sit. But FGS has been a known issue caused by Bilharzia or schisto for over 20 years. It's still one of the, or if not the most neglected sexual and reproductive health issues. And Isis mentioned earlier, it falls in between the cracks because schistosomiasis is treated through mass drug administration, but a woman or girl who has experienced FGS needs to be treated within the sexual and reproductive health kind of branch of things. And these two areas of work are really, there are very few bridges across that. So we're really looking at that intersection. And when I heard about FGS, I just, I couldn't believe that we weren't doing anything about it. And that so few people in the HIV sector, or anyways, the people that I was been working with didn't know about it. And I was also probably just as shocked that people working in cervical cancer or other sexual and reproductive health and maternal child health also didn't know about it. And so, as we do, when we kind of get really affected by something, we start talking to people. And so, what did we start talking to people? Bridges to Development, LVCT Health. Literally, LVCT Health was the first of the frontline AIDS partners that I actually discussed FGS with. And we actually all went to this meeting in Liverpool a couple of years ago. And it just was incredible to us, I think, about what the potential was around changing, it could be life-changing integration for preventing HIV infection among women and girls, but also that broader health, that broader health, holistic care for women. So what is FIG? The FGS Integration Group is literally a group of people, shared ideas, concerns, passions, and we've come together to really build something quite, not systematic, but like something that is focused on FGS integration itself, because it's to get rid of that silo, to break across that silo and build bridges. It's a multi-stakeholder partnership addressing FGS through integrated cervical cancer, HIV, and SRHR approach. It's a cross-partnership and cross-sector innovation, cross-sector innovative partnership, sorry, just because I would have never thought that working with organizations in the neglected tropical disease sector would have any relevance for HIV or sexual and reproductive health. So that's really exciting. And some of the opportunities is strengthening health systems, but including also putting, again, communities at the center, women and girls at the center, addressing that intersectionality and that connection around stigma, discrimination, and gender inequality. And then just really delivering comprehensive and integrated NTD and sexual and reproductive health care. And really bringing together different allies and partners to act together and really leverage our experiences, because there's many times when been having conversations with partners in the NTD sector, and they would say, you in the HIV movement and response, you've done so much around putting, that human-centered approach, working with communities. So the FIG Integration Group, we're taking 5, so the core members, Bridges to Development and Frontline AIDS are really, we consider ourselves like founding members, starting that discussion, convening more broadly, partners AVERT, SCI Foundation, Site Savers, and of course LVCT Health are core members in this initiative. We really see this, and it's us working through 5 pathways to change, and that's based on the different strategies that we mentioned earlier. And one is raising awareness across all communities, strengthening the evidence base. I'm just going to do a little evidence base around FGS integration of FGS within NTDs, HIV, and SRHR, and maternal health services, and mobilizing diverse stakeholders, both kind of people, research, community movements, as well as clinicians and policymakers and the private sector. And then finally, looking at stigma and discrimination and how this is another entry point to really address that. And in particular, because FGS is so often misdiagnosed as STI, and has the same associated kind of results and judgments, really. So I'm going to see like the next. All right, so really the next bit is just to open up the floor for kind of discussion, questions. Wanted to kind of really start with, what are your I can put this back up, but what are your questions and reactions from the presentation. And then we can talk a little bit in a group. I think we're a small group, many of us knowing each other, and even if we don't, we do now. What are the opportunities to include FGS and HIV programming, and what kind of support do we need? So I'm going to stop sharing and just really turn it to plenary and open the floor up for, and I've asked maybe Robinson and Isis to turn your cameras on, and we'll just do a little Q&A session and just a discussion really. So I'm opening up the floor to everyone who's attending, and if it's, like I think, yeah, questions, reactions, because I know that I had quite a strong reaction when I kind of found out about it, and so just work with the a little bit of silence and see who's brave enough to maybe put up a hand. Hi, Elizabeth. Please go ahead and take the floor.
Thank you very much, Alicia and Isis and the team from LVCT. Indeed, this is a very interesting topic, especially for us. I'm Dr. Elizabeth from Life Medical Services in Uganda, and most of our freshwater lakes have are known to be having schistosomiasis. So my question actually first goes to Isis. I was curious to know, maybe I missed it, but in terms of diagnosis, because you had mentioned that some of the signs and symptoms, you have the vaginal discharge, in the event that it is purely just FGS, what sample should be collected and what should they look out for in the sample? Then in the presentation from LVCT, they mentioned that they were able to reach around 1,700 from the safe spaces. I'm curious to know, were they able to find any of them presenting with symptoms, signs and symptoms of FGS? Yeah, thank you very much. Over to you, Alicia.
Yeah, just hand over right to Isis.
Thanks, Catherine, for your question. Yeah, the WHO recommends to diagnose and treat FGS presumptive. Usually, you can diagnose FGS by first collecting urine samples, and then you do a test with a strip, and then you see if there's X or not on this urine sample. And the other way to also diagnose, but you have to be a very experienced practitioner to be able to do so, is to visualizing the cervix. And then there's a series of characteristics that the cervix will present. And one of them is some like sandy patches and also some red papules in the cervix that are characteristics of the lesions and of the egg hatch to the cervix. Those are the two ways of confirming the presence of eggs in the cervix. But again, the recommendation from WHO is if the woman or girl has one of those symptoms that I listed, plus contact with fresh infested water, this girl should be treated with paracetamol. So that's the recommendation from WHO. Please let me know if I answered your question. Yes, and I see that Felicia just posted the WHO Pocket Atlas for FGS. And on this material, you can see all the lesions and its presentation in the cervix.
All right. So thanks, Elizabeth, for your question. So I'll talk about two things that we did during the integration of FGS content in the cervical cancer screening. So the local health center mobilized about 33 women who participated in the training. So they are incorporated as part of the training for pelvic examinations. So out of the 33, the newly trained health workers were able to identify 3 cases of FGS, which was quite interesting because they'd done a previous round of training a few months before, and none of them had reported FGS. So FGS, at least we're happy health workers were able to start spotting or identify or diagnosing FGS. Now, in community settings, our program was more of health education. So we did not do the measurements, to measure the prevalence of FGS. But one of the things that we're doing is sort of like using health records to see if the diagnosis patterns have changed. At the beginning of the study, we did a review of the health records, and we found STIs were very high in the medical records. But now we're actually analyzing the data on if there are any changes in the health records to see whether schistosomiasis is being captured as an issue in the outpatient departments. Yeah, so that is my response to you, Elizabeth.
Yeah, thanks, Robinson and Isis. I think that I just have a question for Robinson. And we did talk about how we build on existing structures. And I know whenever it feels like to me often when we speak to kind of colleagues who are clinicians and working at community level, people almost wince when we say integration because it's kind of like yet another job to be done. So I'd really be interested to hear kind of from your experience around this project. How did people react and how did they take it on? Because I think I always have that in the back of my mind when we think, oh yeah, integration, we'll just add it on. But it's not often that straightforward.
Yeah, it was quite interesting because the DREAMS program had run for about maybe 4.5 years, or 4 to 4.5 years by the time we joined in. So our participants really embraced it enthusiastically because they felt, oh, this is really refreshing. We are talking about something else over and beyond HIV. So having a new topic added onto their continuous discussion was very refreshing to hear. Then the second thing was the community sort of knows about the blood in urine, how of course the myths and misconceptions. So it was very refreshing also for them to start addressing an issue that most of them experience, whether directly or indirectly. So it didn't feel like an additional responsibility, especially in community health settings. Then in the communities, at primary facility level, it was actually very inspiring to hear the health providers say, oh, I last heard about schisto during my college days, and here I am, it's come back, and there's something called FGS. So it was embraced. We were not expecting that, that feedback, but it was very exciting to hear that, they were happy to integrate it and not view it as an additional responsibility.
Right. Well, that's very exciting. I mean, I think I'm going to ask Isis a little bit about this because it's such a great, I don't know, once again, it's almost like for me, it's this great reflection around how FGS speaks to something kind of around integration and that how it's so neglected that it is really, when people find out, they really embrace kind of like, how do we address this issue? So I know that Isis is working on this project called Fast Package, which is focused on training clinical health clinicians, also clinicians and non-clinicians around FGS. And I was just wondering, and they had some crazy, the project is focused on Madagascar and Rwanda. Oh, sorry, Ghana and Madagascar. But they did this online training. They had hundreds of applicants from all over sub-Saharan Africa. But they did come out with some really, some action plans in particular countries. So I just, like, Isis, what is your reflection on kind of people's like willing or kind of excitement in a way about being able to address something that they didn't know about, or the learning?
Yeah, I think as a clinician myself, my first reaction when I heard about FGS was how I could never heard about that. And I think the reaction was similar to my peers in sub-Saharan Africa. Like, how come I didn't know about this and its relation with HIV and HPV? And And one of the testimonials that most, I think, reflects this well was a midwife nurse that she was also a teacher in a midwifery and school university. And she said, how come in 29 years of nursing in midwifery, I never know about this. And then when she thinks retrospective about her own practice and her own teaching, she starts remember cases. Oh, those cases are FGS and those women were neglected in their needs. And with all of these, it comes all the issues that you've explained out in your lecture, saying about stigma and violence, because most of them are misdiagnosed as STIs. And then even you can start thinking even broader when you think about a One Health perspective of health delivery. How many antibiotics were prescribed to no prevail because it did not work, because it wasn't bacterial vaginosis or other bug, it was a parasite called schistosoma. So I think these are the collective sentiment of also as a healthcare provider being deprived of this information and the consequences of this in the lives of women and girls.
Thanks so much, Isis. I see Karen's hand up. Please take the floor, Karen.
Thanks, Bea. And thanks so much to Isis and Robinson for this really, really interesting session. I'm learning so much about this. So for those who don't know me, I work at Frontline AIDS as the Trusts and Foundations lead, so fundraising. And it's no surprise that my question is going to be focusing on what's next and what's needed. Isis, in your presentation, you talked about more research being needed. There's advocacy that needs to be done. But is there a kind of hierarchy of needs in terms of what's next, building from the experience through the Dreams project? Or are there a number of things that need to happen in parallel? It would be good to kind of know, because I imagine, you know, it's so compelling. I would imagine a lot of donors would be extremely interested in this. And I know that there's a separate kind of splinter funding group sitting within FIGS, which is great. But yeah, it'd be great to have a bit of a discussion or some thoughts as to what is felt as the most kind of immediate funding needs. Thank you.
Mm-hmm. Mm-hmm. I can start.
Yeah, go for it.
I've been working in mapping all the evidence available on FGS. And when you divide like in little boxes, of course, it's not very well researched in all the boxes. But one of the most neglected is investigating stigma and violence. So the impact of this neglect on the life of girls and women. And another very very explored is on HPV and cervical cancer. Those are from a very research-oriented evidence map, those are the two areas. But I believe Robinson will have some thoughts on like implementation, and Phil will have some thoughts on policy needs that they will be able to share.
Thanks, Isis.
Thanks, Karen. That's a wonderful question. And it's something we've been addressing in the last 2 weeks after our meeting with the county officials. The key thing, and it kept coming up during our meeting with the county health management team, was how do we build in sustainability? Because a lot of the interventions, the small scale interventions, such as mass drug administrations, are really donor funded. So one of the things that came up during those meetings was really to take our advocacy a notch higher and bring in the county level legislators to approve the program-based budgets, because right now there's zero budgeting for the NTD, especially schistosomiasis, which really is highly prevalent in the area where we are working in. And once we see success, we'd also want to scale that up, our advocacy at national level. So we are targeting both national and sub-national level advocacy on to promote program-based budgeting. And the priority needs that need to be factored in are having counties budget for mass drug administration using praziquantel, which is not, it's really not expensive, but it just needs to get prioritized. Capacity building is another key area, priority for local health financing, and also strengthening the diagnostics system, the laboratory, whether it's urine filtration or cards for other types of intestinal schistosomiasis. Yeah, so those are the three priorities that need to be factored in for local health financing. Thank you.
Thank you, Robinson. I had to chuckle a little bit because I was writing notes on Karen's question, and I was like, Isis and I have worked quite a lot together because she exactly said those 3 points about who was going to speak about what. I think so I'm seeing kind of, the financing piece, or maybe it's like what's next really. I think from a policy advocacy and a really kind of like global or institutional level, I think one is recognition of FGS as a sexual and reproductive health issue with all of its different determinants. So like that's a policy advocacy aspect that it needs to be included. And we've seen some movement from UNAIDS and WHO. I think it's around influencing kind of that implementation of policy into operations. And so that's why I think that work that LVCT and others are doing, we in a way are kind of building into that pathways of change, and we can actually articulate kind of where the awareness work is happening, the evidence work is happening, the engagement work, the integration work, but it's that FIG, or that kind of that aspect of bringing it together is actually where that importance is. I think one of the things that we've also really realized is the voices of women and girls experiencing FGS or the complications are missing from this story or this narrative, which would make a lot of our policy work and our advocacy work and actually fundraising much stronger, is this increasing not just the awareness of FGS amongst clinicians and practitioners, but having real experiences of women and girls also at the table when we're speaking to this. And I think there's also some opportunities, for example, just from a scale perspective, and Robinson had mentioned praziquantel, which is like the key drug that prevents and treats schistosomiasis and has benefits for FGS as well, is that entities such as the Global Fund or PEPFAR, if they were to integrate praziquantel into their HIV programming, that would also, so that type of level of integration and policy and budgeting. And I think just from a diagnostic aspect, there is, I think just as from a fundraising diagnostic aspect to include some of there's emerging evidence of drawing on the research around incorporating self-testing for schisto amongst like this self-care package. Because I think, within the HIV world, we talk a lot about HIV self-testing. We talk, and so many people now also because of COVID, we're doing a lot of self-testing around COVID at home where it's available. So really including, as the technology and diagnostics come live, piloting, testing this kind of self-testing within our kind of self-care packages going forward. Yeah, so I think that's kind of from my perspective around global advocacy or kind of the policy aspects. Let's see, I saw a hand up and now it is gone. Because I think maybe someone might have stepped out. What other kind of questions or reactions might people have? And maybe it's like actually a good kind of, the next question was really, what are the opportunities to include FGS within HIV procuring and advocacy, and maybe even broader, because I know a lot of partners, we're actually working beyond just HIV. We're looking at broader health. We're looking at working with people living with disabilities. And then what do you need to make this happen? So maybe I will, I know there are a couple of people in the room who are working with partners closely, or even just maybe I'll ask Robinson to kick it off about why at LVCT Health you thought it was so important, because you're not only just doing this project, you're actually continuing to integrate FGS throughout your work organizationally more broadly. So it'd be great to hear. Maybe we can start from that point.
Yes, thanks, Felicia. Yeah, so our work won't just end with a project. So we're setting out new agreements for the DREAMS project, where we're scaling it up to other regions within Homa Bay County. So one of the key things we'll do is to scale up with the DREAMS project, and also continuously engage with the health management teams, because advocacy, requires time. So we'll continue that, and our advocacy would also go on to national level. So the two areas of advocacy we'll continue working on and also implementing at community level. Thanks.
Thanks, Robinson. I see Kenneth has joined us back. Welcome. I had seen your hand up before. Please, Kenneth, please feel free.
Thank you so much,
Welcome.
Felicia, and colleagues, for this wonderful presentation. It is quite a good one. My name is Dr. Kenneth Buyinza. I work with the Reproductive Health Uganda as the head of service delivery. But I am also attached to another local CSO initiative as a member of the board, which does quite some interesting work, especially in regard to HIV programming. Now, I had sometime last year when I received the invitation to this webinar, I read about it, and it reminded me of a scenario I encountered last year of a 52-year-old woman who was referred to one of our clinics, because we do cancer screening in our clinics as part of our SRH service package at RHU. But because she was already outside the age bracket where the VIA, the visual inspection with acetic acid, would work, I had to refer her to a colleague at the Uganda Cancer Institute, where she would have a pap smear done. She presented with the suggestive features of cervical cancer with the PV bleeding, especially contact. And when the results that came out actually indicated that on histology, they were able to identify schistosomiasis, hematobium, X. Quite interesting. Actually, she had to be referred to the NTD unit, where she was able to receive praziquantel, and she did well. And then after that, she had to go back for a repeat cancer screening, and it came out negative. Now, we are in a country not so much different from Kenya. Uganda is also home to quite a significant burden of schistosomiasis. And we see populations, especially in the island communities in this country, faced with the very one of the highest magnitude of HIV. These are communities that are actually at a much increased risk for both HIV and African cancer, cervical cancer. Given that, if you look at the exposure to malpractice, they have so many predisposing factors for even cervical cancer, as well as schistosomiasis, based on the kind of the sources of the water they use. So this integration, to me, comes at a very, it is we needed this kind of thing like yesterday, because in here we see the NTD department in Ministry of Health. This is the schistosomiasis among their priority diseases that they look at, but we have this parallel programming, and I think the integration comes at a very right time, and especially for such high risk populations, like I've just mentioned, the populations that live in and around the lake shores. So it is something that we really, I personally, take a very big lesson from. and yet the name has been NTD. Indeed, it is something that has been significantly not even thought about in our SRH programming. So I just wanted to just say that as a comment, a big lesson that I picked from these purposes of programming. Thank you so much.
Thank you so much, Dr. Kenneth. It's honestly, I think one of the things that we're thinking about often is how do partners like yourself, how do we connect through, as our Reproductive Health Uganda, you're part of a huge network of sexual and reproductive health service providers through IPPF. And I'd love to have a discussion with you all also about how we can connect in that way, bringing that kind of that regional network or network of service providers, both at community level as well as public health clinical levels. So I guess I'm where we're a smaller group. I think that this is not I really feel like this is not our first conversation, our last conversation, actually. Maybe we'll say it is our first conversation. Just wanted to open kind of the floor if anyone else had any other comments or close, I guess maybe Isis or Robinson, any other kind of thoughts, and I'm happy to share. I actually have one more slide to share as well. Maybe I'll Isis, I don't know if you all have any other. Isis has shared some information about the FAST package in the chat. So what I would like to ask is if everyone who's interested in continuing this discussion on FGS and HIV integration, could you please put your name, your organization, and your email in the chat, and we will take that as your consent that we can include you as we move forward as kind of key persons in your organization to continue this discussion. So I'll ask people to do that in the chat for now. And then I don't know, I guess any kind of last remarks for today anyway, from Robinson or Isis as our experts in the room.
I could go first.
Sure.
Yeah, so this experience was very enriching, very informative for us, starting from the study through the advocacy. And one of the things that we are currently prioritizing right now is also reaching out to professional associations who are also very critical partners, because through the professional associations, we'll be able to cascade some of this information about diagnosis of FGS and also integration of FGS into their protocols and also into their work plans. Yeah, and we're already beginning to see that people are beginning to consider index of suspicion. So maybe by the end of November, we'll be able to see from the health records if we are beginning to see at least schistosomiasis being captured in the medical records. And our sharing with the sub-national health departments is also helping the teams to start reflecting how health management information data is collected. Because when we trigger the question on how do community health volunteers record NTDs or schistosomiasis, or how do district level or sub-county level surveillance officers, how do they record schistosomiasis in schistosomiasis endemic areas? So a lot of thought triggering processes are happening as we speak. And yeah, looking forward to engaging with FIG to build on these cases and also this work, and also capture the voice of the community as they tell the story about FGS and schistosomiasis. So thanks Felicia for this opportunity.
Thank you. And I have to say a special thank you to Robinson as well, because he has actually come in and spent his afternoon with us when it's actually a holiday in Kenya. So thank you so much. Let me ask Isis if she has any closing kind of thoughts for us.
Yeah, I just want to thank Frontline Leads for the opportunity of raising this issue and speaking about it. I think having the floor is already a good start. And I also want to acknowledge if there is anyone here in the group that wishes to be part of community of practice in genital schistosomiasis, so not only FGS, but also male genital schistosomiasis, you can also go to the Global Schisto Alliance website, and there you can
share.
I will share later. You can find the link to be part of the group. And then if you encounter a case or need some support, this group will be there for you. Thank you.
Let me just I can actually, did I not do it? Hold on, let me just do this real quick. I'll just stick that. So this is what Isis is speaking and talking to. We'll just stick it into the chat, but it's the Global Schistosomiasis Alliance. They have a community of practice that's been really interesting and really very much welcome practitioners on the ground and partners from HIV and other sexual and reproductive health work joining. Okay, I'm just gonna stop sharing. Thank you. I just want to thank everybody so much for their time today. There is just a little bit about timelines, and actually the FGS Integration Group, please, please say in the chat here or email myself or Jackie, who sent out the invites to this session, if you're interested in joining up. We will be having, there will be an event at the American Society for Tropical Medicine and Hygiene around FGS, well, actually it's NTDs and sexual and reproductive health. We're hoping to have a session at ICASA coming up in December, as well as a couple of things that might be quite interesting. We will be putting together a page on the Frontline AIDS website around FGS, which will have obviously the link to this recording of this session and other resources, but also Isis has been working on a evidence map. So you can actually, there's just one place where you can go to see what evidence is already out there, from kind of single studies to peer-reviewed journals to some of the gray literature. And we'll make sure that we'll also obviously, when it's ready, link to the LVCT project and outcomes from that. So please just, we will just continue to kind of, I think, keep it going. And World NTD Day is 30th January. We're hoping to have some, so watch out for that. And then sometime, and we're thinking hopefully maybe AIDS 2022, just like a real official launch of the FGS Integration Group. But so it's all in the works, and thank you for being here with us in the start of things. And I think that we'll close the session for today. Thanks so much for your time, and have a good rest of the day, everybody. And see you soon.
Bye.
Bye.